we're going to talk about managing stress and anxiety. And Roberta, please let me know if you can't see the slides. I think you can.
We're good.
All right. Oh, I had this happen yesterday. There we go. So what is distress? It's a multifactorial, unpleasant experience. It can be psychological, it can be social, it can be spiritual, it can be physical. Stress is a normal part of everyday life, but when you have sort of extreme or out of the normal stresses, like having cancer, it can be much more a part of your life. And under the anxiety section, we'll talk more about that. It can interfere with people's ability to cope with everyday life or their illness. And it can cause problems that can be very disabling, such as depression, anxiety, social isolation, existential or spiritual crises. And again, we'll go into some more detail a little bit later. So distress is along a continuum. There's sort of normal adjustment to changes in one's life. There's sort of the extra stress of having a sort of higher than normal stressor. And then there's things called adjustment disorders, subthreshold mental disorders. I don't really like that term, and then diagnoses as well. And we'll talk more about that later too. So what are the risk factors for being distressed? Well, a younger age. And if you can imagine, it's more of a shock to get cancer when you're in your 20s or 30s. And for those that might have a life-limiting cancer, it's the greater loss of potential or the story of their life that they thought they were writing and are not going to get to write. Or if they're going to survive, it's certainly going to probably be a different story than they imagined. Spiritual or existential distress, and a lot of social factors. So the ability to communicate with your care team, how much you understand or are able to understand about what's going on and what the doctors are saying and how well they're communicating that. Family conflict, lack of social support, living alone, unstable housing, immigration status, children, financial issues, food security, which we've been hearing a lot about lately in the news. And if you want to chime in the chat of some other stressors you can think of for people with cancer, please go ahead and do so, because this is just a list of the major ones. Also, uncontrolled physical symptoms, a major cause of distress. And then mental health, so past traumas, poor mental health before you were diagnosed, having a pre-diagnosis of a mental health disorder, and substance abuse issues. So what often triggers the distress? Well, new symptoms or worsening symptoms, either prior to the diagnosis or after the diagnosis. Testing and waiting for the results, both prior to being diagnosed with cancer, during treatment, and then also post-treatment surveillance. Find a lot of patients that will tell me that they're distressed or anxious for the week or the day before they get their scans, and then that continues until they get their results. In fact, I have a patient, a new patient from that comes to Cedars from San Diego, because in San Diego it takes a week to get her scan results back, and at Cedars she gets them same day, and she can't tolerate. She'd rather tolerate the 2-hour drive in Southern California traffic than tolerate the week of waiting for her scan results. So learning that the diagnosis is cancer, waiting for the start of treatment. It often takes more time than patients expect. And when you hear the word cancer, you expect that you need treatment right away. I'm not an oncologist, but my understanding is the oncologist understands the urgency or non-urgency of starting treatment and how much of a difference it'll make. So for those that it's less urgent, they may wait longer than they expect to get started. And hopefully it's been communicated to them why and how that does or does not impact their outcomes. Treatment-related side effects, of course, cause a lot of distress, fatigue, radiation burns, nausea, all of those things. And some of the treatments cause mental health symptoms, so depression, anxiety, etc., which we'll also talk about more later. And then transitions in care, being discharged from the hospital. I find a lot of patients, the stress, the anxiety, the psychological issues hit at the end of treatment. From diagnosis through treatment, it's a focus on how am I going to get through this? I need to do everything I need to do for my treatment. I need to take care of my life, whatever that may entail, work, kids, whatever. And that the psychological impact is sort of not noticed until that's all done. And all of a sudden you're not going to the cancer center all of the time. And you're not as connected with all of the caregivers as much. And that's when the stress really comes out. Changes in lines of treatment because treatment didn't work. Cancer becoming advanced. Transitions to supportive care only if there's no longer any cancer treatment options. There's always treatment options to support people's symptoms and psychological state, but there may be no more treatments for the cancer. And then even long-term survivorship, patients continue to have impact from their cancer experience and or the side effects from their treatment, or sometimes some survivorship guilt because they're doing well and they know people that did not do as well, who went through similar things. So it can impair your ability to function daily, interfere with sleep, and I find sleep is one of the most important things for any medical, psychological disorder, symptom. Everything gets better. It doesn't go away. It might only be 10% better. It might be 70% better. But when people get a good night's sleep, distress causes a decreased ability to focus. People feel more isolated or choose to isolate because they're distressed. And of course, that makes the stress worse. It's harder to be a caregiver if you're a parent or caring for your parents or an employee. It can impact your ability to make decisions and think clearly, or decide what's best for you. It decreases medication adherence, and we know from a lot of evidence that the less people adhere to their care plan, the poorer their outcomes as far as cancer care and quality of life. Often people have lower levels of exercise and other healthy behaviors. They'll let their diets go, they'll stop exercising. And it's really interesting from a psychological perspective because I think we can all relate to, well, I'll start running again or whatever I'm doing when I feel better, but it's actually the engaging in those behaviors that will make you feel better. Assuming you don't have physical things that limit you from doing them. And that's a whole other can of worms. I have some patients where hiking, exercise, running is a big deal for them, but now they're not able to do that because of their disabilities. It causes more missed appointments, which can worsen symptom control and outcomes. So the less that we are able to see you and assess you and intervene, the worse things can be. And it actually worsens immune system function, overall health, quality of life, and length of life. And there's some really good evidence around this from several areas of medicine. So what are some approaches to distress? Relaxation training, being educated about what to expect, what you're going through, what's going to be coming, those kind of things, to the level that you want to know. There's some patients that don't want to know anything and want to live day by day, and there's others that really want to know everything. And I think I talk about this more in the anxiety section, but I'll say it here, that physicians and oncologists often make the mistake that when a patient is stressed or anxious, It's better not to give them information because it's going to worsen their anxiety and stress, when it's actually the opposite. The more information people that are anxious have, the better they do. There's individual or group counseling and talk therapy, existential therapies. Of course, social support can be, or family support can be a major thing, or group and peer support as well. I have a patient who's doing all the right things for her stress and anxiety, including signing up for a buddy program so she can hear from somebody else that's gone through what she's going through, and she's young, she's in her 30s. So there's not a lot of people in that group. And so for her to find somebody else to go through that has gone through it, she finds really helpful. Other people, it doesn't always help. There's no fix-all for everybody. Group therapy is not always the best for every person. So self-management of distress. So if you're distressed and listening to this, these are the things that you want to work on, either by getting some help from a specialist, or using Dr. Google from good sources. But problem solving, how do we solve problems? How do we make decisions? How to best use your resources? How to communicate and ask questions with the healthcare professionals? How do you get them to tell you the information that you want? I often feel that we can be more precise with prognosis. Now, again, I'm not an oncologist, and trajectory. We don't have crystal balls, but we do sort of know worst case scenario and best case scenario and average scenario, and what our experience scenarios have been given other patients like yourself. So those are often how I coach patients to talk with their oncologists. And we'll also offer to have those conversations with the oncologist, with the patient. It's usually our social workers that will do that. And of course, task planning and goal setting. So a lot of patients feel stuck, like they can't get anything done, poor motivation. So how do you manage that with stress? So I also want to talk about provider approaches and what you might expect from your providers. I'm going to take a quick little drink here. It's a little dry here in Southern California. Such a rough life, I know. We have to consider the whole person. And for those of you that know Maslow, this is based on Maslow's hierarchy of human needs, but adapted for illness. And so number one, we have to make sure we're taking care of people's physiological issues. And the idea is, if you are not functioning well at a lower rung, you're not going to be able to function at a higher rung. Because if you're in pain, you're not going to be able to focus on anything else. Oops, I went backwards. So safety, advanced care planning, safe environment, promise not to be abandoned. If death is in the picture, imminent, that it's a safe death and the death that you want. If death is not imminent, it's the care that you want and the life that you want, feeling safe and that you will not be abandoned. Feeling loved, so this is the social and practical issues, family and community, esteem, and this is psychological issues, dignity and self-control, and self-actualization, which very few of us achieve, but that there's a meaning, value bigger than ourselves, that we're part of something greater, or spiritual issues. I find cancer patients achieve this more than the general population. Now, while I said that in order to get to higher rungs, you need to have your issues taken care of at lower rungs, but of course they interact. If you're depressed, your pain's going to be worse, and vice versa. So it's not so simple. But the point is that we need to be looking out for all the issues that impact your life and your care. We need to appreciate your concerns. And I think this is shocking to physicians when I give this talk. These answers are from patients with advanced cancer that were on hospice, but I find apply across any cancer patient, and there is data like that. But number one concern of patients is loss of autonomy, ability to participate less in enjoyable activities, a loss of dignity, losing control of bodily functions down at 50%, being a burden on others, and concern of inadequate pain control all the way down at 21%. So I want you to think about, and maybe you can also chime in on the chat, for how often doctors ask you about these things. Because in my experience in training, it's walk in and ask you how your pain is today, look at your vital signs, see what symptom that you're in, but not a lot of asking about those top three at all. And this is similar. So this is a similar set of cancer patients with advanced cancer, and that what they say affects their sense of dignity. And dignity means, worth or value. And patients saying not being treated with respect or concern, feeling like a burden, feeling a lack of control, feeling that life is meaningless or that I'll leave no lasting impression, bodily functions, and not feeling worthwhile their value. So again, just one of the things on this list is medical or physical, and yet what we're mostly focused on when you come to the hospital is the physical stuff. So we really need to understand what's most important to you. I have so many patients that, the cancer treatment, they can get through that, but they're really struggling to explain to their family what they're going through, or take care of their kids, or worried about losing their jobs, or feel like Dr. X or Nurse Y did not treat them respectfully. And yet, as a medical field, we don't ask these questions. I'm not talking about me or my team or specifically Cedars-Sinai. I'm talking about healthcare in general. I can't say that we're perfect at this at our program as well, but certainly I try to drive this home any chance I get.
Dr. Irwin, I just give you an overview of the many people that chimed in. They are claiming that no one has ever asked them how they're doing, and that seems to be the consensus across everybody that said something.
So I'll ask them a follow-up question then that they can chime in is, would they like to have been asked these questions? And do they agree that these are sort of top of mind things for them as well as their cancer treatment and physical symptoms?
Okay, I'll let you know what they say.
Okay. And we can't forget about families. At last time I checked the data, 65 million caregivers deliver care at home to a seriously ill relative. 40% of them are delivering 20 more hours of unpaid care, often when they're working themselves. 87% state they need more help. 33% are in poor health themselves, and often the caregiver stress leads to poor health. Stressed caregivers are significantly increased risk of their own medical issues, depression, reduced quality of life, loss of work, and actually die sooner than those of us that don't go through this experience. The economic costs are thought to be about $375 billion a year in the US alone. And I know we have many countries online today because of this beautiful virtual nature of this. So it's much more worldwide. And respite is needed. I'll often talk to both the patients and their families that the caregiver needs a break. If the caregiver can't take care of themselves, that they can't take care of other people. It's kind of like the, you put your oxygen mask on first on the airplane, then you help others. Because if you don't put yours on, you're going to pass out and not be able to help anybody else. It's the same type of thing. And we need to do better as a health system or as a country of providing these opportunities for respite. But some do exist through palliative care programs, which aren't hospice programs. They may be affiliated with hospice programs, and other things like, I'm not sure if American Cancer Society is offering it currently. Their offerings change time to time, but there are abilities to get respite care or have people come in and give you a break for a couple hours as well, or your loved one. And I remind the patients too that they may have a lot of needs, but that their caregiver has needs too, and that we need to make sure both of them are operating at maximum function. The other evidence is that if the caregiver is not doing as well, the patient's not doing as well, and vice versa. So here's the anxiety section of the talk. And Roberta, I don't know if people chimed in on my follow-up questions.
They did. There's a couple comments that I wanted to read. Let me see. My longtime doctor was never concerned about how I felt. Everything was just science-based on numbers. Anytime this person mentions to anxiety or not feeling happy to their endocrinologist, it's just shrugged off because the TSH seems normal. Kelly said, we wished we had been asked these questions and we have been on our own to find a therapist to help our child with cancer. It has been an uphill battle to find someone that can understand how to help her. So I think the overwhelming majority of people are looking for that kind of concern.
Yeah. So what I can say is, and I'm sure you've all experienced this, having had to be part of the healthcare system more than other people because of your cancer, you really need to advocate for yourself. Find out what resources are available at the institution. Find out what resources are available in your local communities. Call your local American Cancer Society, who often is plugged into resources, or the cancer support communities where they have them. And of course, I know this is very US centric and I apologize for that, but if you're in other countries, similar type of things. That said, I will say that, we have many, many areas in the US that don't have access to good mental health care or behavioral health care. So now that it's a new virtual world, maybe that will change to some extent, but really advocate for yourself. And the other thing is, not all physicians are a good fit. I will say I'm not a good fit for everybody. I might or might not be a great psychiatrist. And if I am great, I just might not be the right fit for somebody. That's okay. Some of you might not have choices, or some of you might have chosen someone because they're the best in the field. Often they're the best in the field is because they give talks like this and write lots of papers, but that doesn't say anything about their bedside manner. So you need to do the best that you can. The cancer support communities, I know in LA, we have 5 of them, are now focused on all of California, still trying to stay focused on their previous geographic region of the LA basin. But there's so many more people that are getting access now because all their programs are virtual versus having to go someplace, especially with Los Angeles traffic. So there may be opportunities for those of you that don't have resources near you to connect virtually with something that's in your state or in your city or nearby, and hopefully one day across state lines as well. So what is anxiety? It's an expected normal transient response to stress. And it may help with warning of danger or coping with the stress. This is evolutionarily important, so we weren't eaten when we were in our primitive state. And now it tells us when there might be danger, or I have a pain in my back, I need to get that checked out. So what is pathologic anxiety? Well, that's when an excessive response to an external stress, or often there's an unknown internal stimulus. And we'll talk about the characteristics of pathologic anxiety. Often there's no recognizable trigger. It exceeds your ability to cope with the stress. It's often persistent instead of transient. And people have impaired coping, disabling behaviors, avoid things like appointments, or withdraw from their care or their loved ones. So there's often physical symptoms that can go with it. So fast heart rate, fast breathing, sweating, diarrhea, dizziness. The affective, which means the mood component, being edgy or irritable, sense of terror, feeling like impending doom is around the corner. And then the behavioral things, we talked about the avoidance, or maybe compulsions, which I think now we all have more compulsion to wash our hands, which is normal in this new world state. But they might have other compulsions because of their cancer, maybe about the way they eat, or where they go because they're concerned about their immune systems. And then psychomotor agitation, that's the people that are sitting next to you in the movie theater, and you may be one of those people that are always tapping their foot or tapping their hand and just can't sort of sit still. It's that nervous energy type of thing. And then what I see most in my patients is the worry, the apprehension, obsessions with how life or treatment is going to go, being fearful, dreading what's going on. And often this stuff comes just as you're trying to go to sleep, or you get to sleep, but you wake up at 2 a.m. and can't get back to sleep because of these things. So it's pretty prevalent, one of the most prevalent psychiatric disorders in the general population. Up to 25% of the US population lifetime. And I'm sorry, I don't know the world number, but typically the US tracks with the world numbers. Up to 21% of cancer patients would have a diagnosable anxiety disorder. So it's a little bit less, but up to 70% have persistent symptoms of anxiety, and almost 100% within the first month of diagnosis. And for most of those patients, it goes away once treatment is started. And really, my program needs to focus, while we target everybody, focus on those 20% that are really still struggling after that first month. And of course, we help during that first month too, but we don't want to jump to conclusions that this is severe and needs us to jump in and intervene other than being supportive. I don't want to prescribe medications for something that might go away in a few weeks. Often there's no previous history of anxiety. It's greatly increased if you have a first-degree relative with an anxiety issue. And it's often or underdiagnosed, or we heard from the comments, sort of brushed aside. And I'm guessing brushed aside because that person is at the end of their comfort zone or knowledge about what to do next and doesn't know what resources to do next, or there are no resources available where they're practicing. I mean, it could be other reasons too, but those are some of the big ones. I also hear a lot, oh, well, of course they're depressed, they have cancer. Of course they're anxious, they have cancer. Well, like I just pointed out, it's really only about 20% that have a disorder. So that means 80% do not. So it shouldn't be dismissed as something that we can't address, or that is just a normal part of going through cancer.
Dr. Irwin.
Yes.
There was a comment about a question about if suppressed TSH contributes to anxiety. And I think that you'll find a lot of people talk about how they are having anxiety feelings, but they are TSH suppressed. And that's something that people haven't been able to kind of ferret out. So this particular person was asking about that, and then also asking if anxiety and depression are the same thing, because in this person's experience, the doctor was giving the same medication for both. So I guess the first question is whether or not a suppressed TSH causes anxiety, and then the other question is about depression and anxiety.
So the second question, I believe, is addressed a little bit later. So if we don't, we can circle back if we don't answer those questions. The first question is, TSH is really a screen for whether there are thyroid hormone issues, the T3 and T4. And I would assume that most of you get a full thyroid panel and not just a TSH. I could be wrong. And again, I'm not an endocrinologist or an oncologist. So what I would say is that excessively high thyroid can cause anxiety and maybe this like over caffeinated feeling or the excessive psychomotor agitation. Of course, those of you that are on supplementation, you want to hit the normal level. Low thyroid hormone leads to depression, not anxiety. And we'll talk about the differences between anxiety and depression, which is part of that question in a moment.
Thanks.
So many cancer patients also develop post-traumatic symptom disorders, symptoms, if not the disorder itself, from going through the experience of getting the diagnosis, getting a poor prognosis. A patient with severe PTSD from his experience with radiation. And we'll talk a little bit more about what PTSD is in a moment. So this is data. This is what we use to screen patients for all sorts of issues. These are the top issues that patients, basically cancer patients, sort of talk about for themselves. And what you're looking at is about 4,000 administrations in 2,000 patients over a couple of years. And the red is those saying severe distress, and orange is moderate distress. And you can see for almost all of those issues, it's about 20% all the way up to 60% of any given encounter with these patients. And then you can see that worry and anxiety is in the top 3 of what they report. And this is just from 11 pilot clinics across our many, many cancer clinics at Cedars. Cedars, by the way, I believe is the first or second largest provider of cancer care west of the Mississippi. So we see a lot of patients. So what is the course of anxiety? Well, it can cause significant impairment in physical and psychosocial functioning, significant decrease in quality of life, just like we discussed with distress, increased alcohol and substance abuse, marital or partnership problems, family problems, work-related problems, and it is a risk factor for suicide. Patients will improve with treatment. However, few achieve full or sustained remission, meaning that it often doesn't ever fully go away, or if it does, it will likely come back. So it's important to have maintenance therapy, just like you have surveillance therapy for your cancer after the initial treatments. So here's some questions you can ask yourself, and you can think about it. Think about these. Do you worry a lot? Like most of the time? I mean, we all worry some. That's normal. But are we always worrying? Does it take up a lot of our time? Are you often fearful? Do you feel anxious, nervous, or on edge? And I'm not talking about if you're standing in front of 500 people you can't see, or how many are ever on this chat. Maybe it's, I thought last number I saw was 30. I'm talking about, you know, when there doesn't seem to be really issues that are you know, causing that. There are tools that you can go find online and take yourself to screen for if you might have anxiety. Again, these are screens. They're not diagnostic. Doesn't mean you have an anxiety disorder, but it gives you a sense of if you might want to follow up more with somebody about this. So these are the main anxiety disorders, and I'm going to quickly go through the ones in green here. So adjustment disorder with anxious features. And so these are the diagnostic categories in the Bible of psychiatry, which is the DSM-5. Some of them you have to take a little bit of grain of salt in the cancer arena because there are overlapping symptoms and other things, as was pointed out, with thyroid levels, which we'll discuss again. But I find it's a good jumping off point. So it's a reaction to a stressor within 3 months of the onset of a stressor, like a diagnosis of cancer. It lasts 6 months after the cessation of the stressor. Well, in our world, often the stressor doesn't go away. So the diagnosis was really written for things like divorce or loss of job or something like that. But what I find is it's people that really don't meet the criteria for a clinical disorder or people that I would provide medication to necessarily, but that they're having more stress than their baseline and then sort of normal. So it's in excess of what is expected. I don't know what's expected when someone's diagnosed with cancer. I think this is also a little bit silly, but you put it in the context of that person's life and their experience. And again, not meeting any of the sort of more severe diagnoses. But it can really impair people's functioning. So these are the people I often think of for talk therapy, maybe a little sleep medication, but I wouldn't necessarily jump in with an anxiety medication for those people, but definitely support and counseling. Panic disorder, sudden onset of intense fear, apprehension, or this feeling of impending doom, like I'm going to die. It comes out of nowhere in unexpected situations, and they're short and discrete. They often last 15 to 30 minutes. So when a patient comes in and tells me they're always panicked, that's usually something else, not a panic attack or panic disorder. And in the general population, not cancer, it's not infrequent that we hear about first episodes of someone driving down the highway, not being stressed, which is hard to do in Los Angeles, but and then all of a sudden have to pull over to the side of the road and think they're having a heart attack, often in their 20s or 30s. And it's the first episode of panic. Often physical symptoms, a shortness of breath or choking, racing heart or palpitations, chest pain, shaking, sweating, hot flashes, dizziness and tingling, or a fear of going crazy, losing control, or, oh, this is going to cause me to die in this moment. Take another drink here real quick. Post-traumatic stress disorder. So there has to be a traumatic event, including diagnosis of something like cancer or going through some of its treatments. People often have nightmares about these things, intrusive memories about these things. They'll feel like they're re-experiencing it. They'll avoid things that remind them of that. So, you know, a lot of the PTSD research comes out of our veterans. So they'll avoid watching war movies or things like that. Cancer patients sometimes, if they're not going to the cancer center, might drive a route so they don't have to pass it on their way to where they're going, that kind of thing. Feeling hyper aroused all the time, always sort of on edge or nervous. And then always scanning the environment for danger. And again, so this might be in the cancer world that every symptom, because we all get physical ailments, every symptom is a cancer recurrence or a new cancer. And of course, it's normal to worry about that a little bit. It's not normal to think every single thing is a major catastrophe, but it might be worth getting checked out. I'm not downplaying that at all. The example I like to use for hypervigilant is, again, with the veterans, I'll often ask them, and this is back when I was working with veterans, and I get some veterans now as well, but often they're in the VA health system. I'll say, Mr. Smith, if I walked up behind you in the waiting room and I put my hand lightly on your shoulder to say it's time for your appointment, what would you do? And I get two answers. The first answer I get is, Doc, I like you a lot, but I'd break your arm. Or two, I would never, ever sit where somebody could walk up behind me. So that would not happen. So that's what hypervigilance is. Dr.
Irwin?
Yes.
There are there's a couple questions in here. So okay. So someone is talking about their experience from PTSD and was wondering if EMDR is something that they could use for PTSD. And then also a couple other people are wondering if, they are advocating for themselves, but they're looking for some tips or tricks and advice from you about how that they can, what can they do to help them through their, I guess, the tough times that they're having, but then also how to advocate for themselves for when they do need help.
Okay. Let's circle back to the second part of those questions at the end. I may address some of that, and I'm trying to be mindful of time because we're getting close, but I think we're getting close to the end of the presentation. Okay. EMDR can be very helpful for people with trauma. It's one of those things where it doesn't hurt to try and see if it works. And if it doesn't work, it doesn't work. I often feel that, we all have traumas in our life. Some might be minor or happen to all of us, and some might be more major, like what we're going through now with COVID for all of you that have had cancer. And trauma can be cumulative, so that you may not really have PTSD from a single event, but you've had several traumas in your life where your coping is impaired because of this sort of cumulative trauma. And the EMDR can be good for that as well as other things. But I look at trauma-induced anxiety and other things in a slightly different way, because I think psychotherapy is important for all anxiety, but so much more important to get sort of trauma specialists involved for those patients. So generalized anxiety disorder is constant excessive worry lasting greater than 6 months, impacting day-to-day activities. My screening question for this is, would your friends and family say you're a worrier? Yes. Or they'll say, I'm the one that carries the worry for everybody, or I'm always worrying. That's a generalized anxiety disorder. So the other thing to realize is that there's medical causes of anxiety, and this is back to your thyroid question. So is it medical or is it a primary anxiety disorder? Often it's medical if the onset is after age 35, if there's a lack of personal or family history, or if you're not responding to anxiety medications. And of course, you need to assess for other psychiatric disorders. So while depression and anxiety are different, some people can become anxious because of their depression and how it's impairing them. Or some people, their anxiety is keeping them from doing the things they love, so they become depressed. And it might be that we target the one and not both, but to sort of preempt the other question, the medications are often the same to treat both. Neurological insults and syndromes, hormonal imbalances, and this is back to your thyroid question, electrolyte imbalances, cardiac abnormalities, breathing abnormalities are all possible causes of anxiety. So we as physicians need to do our job. That person that pulled over to the side of the highway thinking they had a heart attack, we got to check and make sure if they did or did not have a heart attack before we just assume it was a panic attack. The medications or drugs that we take, I call them the EANs: caffeine, cocaine, amphetamine, theophylline. Many of you are on levothyroxine, corticosteroids, and then the levothyroxine at the bottom. So yes, too much can cause anxiety. So how do we manage this? And that was one of the questions that came up. Supportive counseling, the self-management tools we talked about before, psychotherapy, relaxation, pharmacotherapy, and often combinations are best. Head-to-head, psychotherapy and medications work about the same. Together, they're synergistic. Psychotherapy takes longer to work, but if you stop it, it lasts longer. Medications work more rapidly, but if you stop them, the symptoms come back faster. So helping people improve understanding of what their situation is, what they can modify, like not drinking 3 pots of coffee a day, or how they can reduce stress in their life or major stressors, help create a different perspective of what they're going through or their treatment or sort of the new normal, which is what we're all living with in this post-COVID world. And then helping people identify their strengths and coping strategies. I find when they become anxious, they forget that they used to know how to cope. So I said exercise is important for lots of people, but they often stop exercising when they're not feeling well, when it's actually the exercise that's going to help make them feel better. For the people that can't exercise anymore, it's finding ways they can exercise differently or what you can substitute. And one story I have is I had a patient who was like a national manager for a major real estate company who was dying of his cancer, not imminently, but within a year. And he couldn't tell his kids that he had cancer and what the realities were. And I asked him, I said, in your job, have you ever had to have difficult conversations with employees, tell them things that they may not want to hear or may react strongly to? Yeah, I have to do that all the time. How did that go? Oh, I'm really good at it, and I'm really good at managing the emotions and handling the questions. Do you think you could use those same techniques with your kids to tell them about this? Oh, well, doc, I never thought of that. Yeah, I could do that. So reminding yourself what's worked for you in the past can also be important. So these are the psychotherapies. CBT is the most researched and why it's mentioned the most, but it can be very helpful. Group therapy in cancer patients has been shown to be helpful. Existential group therapy focused on meaning and value, and also dignity therapy, which is a specific therapy often focused towards patients at the end of life, but no reason we can't use it earlier as well. So I hope we have time for this. I'm gonna do it anyway. I want you all to imagine yourself at your favorite beach. If when I'm doing this with a patient, I'll ask them their favorite spot, so it doesn't have to be what I choose, it's what they choose. And I want you to take a deep breath, and I want you to slowly close your eyes. Now I want you to imagine you're at your favorite beach. Take a deep breath and smell the smell of the surroundings. I want you to look out at the sand. Notice where the sand changes from dry to wet, where the water is slowly rolling in, where the waves are crashing. Look out even further as you see the waves roll in. Look even further out and notice the horizon and the contrast between the water and the sky. Look up in the sky, notice if there's anything there, like clouds or birds or kites. And then I want you to look back down at yourself and maybe focus on your feet. And if they're touching a towel, what that towel feels like, or if they're in the sand, what the sand feels like, what the wind feels like blowing across your face. Maybe if you're getting some ocean spray. And then I want you to listen and listen for the sounds around you. Maybe you're by yourself and all you can hear is the water and the waves, or if you're at a lake, the lapping of the lake. Hear the wind going past your ears. Hear those things that might be around you. Now I want you to take a minute and take in all of those things, the sights, the sounds, the smells, the feelings, and just think about being at that beach and all of those sensations. Now I want you to slowly take a deep breath and slowly open your eyes. And if you want to chime in to the chat, how you feel now versus how you felt before we did this, please do. I find that in large groups, I did shorten it a little bit, but in large groups, there'll be people that fall asleep and have trouble waking up, and really anxious people that can't even close their eyes or close their eyes but continue to tap their feet or what have you. But this is called guided imagery, and it takes less than 3 minutes to do with a patient. And now you all know how to do it, and you can do this at your desk or at home or after you put the kids to bed, and it takes 3 minutes to do, and it just took me about 3 minutes, 5 minutes to teach you how to do it. So this gets to the other things about the coping part. There's all sorts of things like guided imagery, muscle relaxation, a lot of medical evidence for hypnosis. I know a little bit about hypnosis, and if I do guided imagery under hypnosis, it seems to work better. Meditation, massage, aromatherapy, healing touch, biofeedback, exercise, making sure we're all getting bright light. Best is at least 30 minutes a day with no sunscreen, no glasses to get the effects of the sun. That's of course assuming that your skin and eyes can tolerate that. Now that we're all isolated, some of us are outdoors more, but some of us are outdoors less. Avoiding caffeine and alcohol and making sure people are getting good sleep are all very important. So the medication points, so the antidepressants are also the main treatment for anxiety, back to the question about using the same thing. So depression is someone who feels depressed, sad, down and blue all day, every day, doesn't get joy in life, versus what we've talked about with anxiety. People can have both separately, or people can have one causing the other. But the treatments are pretty much the same. Benzodiazepines, these are your lorazepams and your diazepams, and a medication I really never recommend, the alprazolam. So the more common terms are Xanax, and that's the alprazolam, or Ativan or Valium, or Klonopin or clonazepam. Often medications like gabapentin, for those of you that might be on it for neuropathic pain, can be used for anxiety. And if you're using trazodone for sleep, a little bit during the day can also help with anxiety. Just back to the antidepressants. So they take 4 to 8 weeks to work, but they're often well tolerated. These are the serotonin reuptake inhibitors, the SSRIs, once daily dosing. For anxiety, you want to start with lower doses because every one of them can also cause anxiety as a side effect. And so we have to see if you have that side effect. And just because you have it to one doesn't mean you'll have it to another. And just because one is ineffective doesn't mean another one will be ineffective. It's a little bit of trial and error. But you need higher doses for anxiety than depression. So for those on Lexapro, 5 milligrams is pretty low. 10 might be enough for depression, maybe 15, but you probably need 15 or 20 for anxiety. So we want to get you up to the highest dose that gives you benefit without any side effects or as few or at least tolerable side effects. You want to check for medication interactions with all the other medications that you're taking. I find that Wellbutrin XL is, and I don't work for them, it's also called bupropion. I don't make any money from them. That's my go-to drug for both depression and anxiety. It works for both, even they'll often say that it doesn't work for anxiety. And there's other drugs like Effexor or Cymbalta that you may be on that are also good for anxiety and depression. I see Roberta's popped on screen. So this is my last slide. Although the world is full of suffering, it is full also of the overcoming of it by someone who knew a lot of suffering, Helen Keller. For me, I think it's by strengthening meaning, value, and dignity in our patients, both medically and otherwise, and doing this through transdisciplinary care coming together to be better than the sum of our parts.
So thank you so much for everyone for joining us. And thank you, Dr. Irwin.
Thank you all. Thank you very much.